Dr. Nader, when do you want me to start?
Hello, everyone. Welcome to our Zoom meeting. Today we're going to talk about different topics as listed, and Dr. Marwa and her team will be presenting these important topics. Hopefully, we will benefit from it. Thank you so much, Dr. Marwa. When you are ready, you can moderate the meeting. Thank you.
Thank you, Dr. Nader. My name is Marwa Mohammed, and I will moderate our meeting for today. So first, I will share the agenda. Our first topic is hypertension, presented by Dr. Kareem and Dr. Alaa Hamid. Our second topic is research career development, building a research portfolio and balancing clinical work with research, Dr. Mahasin. Our third topic is confidence interval, presented by Dr. Mohammed makawi. And our last topic is 10 steps to being more sociable, how to talk to anyone with ease and confidence, presented by Dr. Alzain. And for projects updates, we have two new apps. The first one presented by Dr. Iram, and the second one presented by Dr. Wissam. So, Dr. Kareem, you can start whenever you are ready.
Can I please share my screen? Can everybody see my screen?
No, not yes, we can now.
Okay. So, good evening, everyone. My name is Dr. Iram Siddiq. And I'll be giving a short talk today about hypertension. Sadly, my colleague, Dr. Ala, will not be able to join us today. So I will be taking her part and presenting the whole thing today. So starting with the objectives of today's talk about hypertension. So by the end of this session, I'd like you all to be able to understand how to diagnose and treat hypertension, especially in older adults. And secondly, we'll discuss when to recommend lifestyle modifications to older adults and choose among the various different classes of antihypertensive drugs wisely. And finally, we will talk about how to apply principles of adjusting drug therapy in real life practice. So the topics that I'll be covering today regarding hypertension. So here's our roadmap. I will be talking about the physiology and epidemiology of hypertension. We'll be talking about how to clinically evaluate hypertension. And we will also talk about how to treat hypertension, both environmentally or through lifestyle modification and pharmacological treatments. And we will also talk about how to follow up with hypertension patients. And finally, we will have a small discussion about hypertensive emergencies, urgencies, and long-term setting or long-term care. So to begin with, we'll be talking about the epidemiology of hypertension. So blood pressure tends to rise with age, particularly systolic blood pressure and pulse pressure. So among Americans aged above 65, about 50 to 70% were found to have hypertension. It's more common in women than men, and it's highest among Black individuals. So, but despite the available treatment options, still the control of hypertension remains disproportionately low, and this is highly suggested by the lack of medication adherence in the community. So now we'll start with knowing how to classify different stages of blood pressure or hypertension according to the blood pressure levels. So a normal blood pressure is briefly defined as blood pressure that is under 120 systolic and 80 diastolic. Then we have a stage that's called a pre-hypertension stage, which is when you have your systolic blood pressure between 120 and 139 millimeters of mercury and a diastolic between 80 and 89. Then we can any blood pressure above 139 systolic or 89 diastolic is regarded as hypertension. And then hypertension itself is divided into two stages, stage 1 and stage 2, with stage 1 being between a systolic blood pressure of 140 to 159 or a diastolic of between 90 and 99, with stage 2 being any systolic blood pressure above 160 or diastolic above 100. And the diagnosis should always be based on multiple readings across multiple visits, and we should never only rely on one measurement. So sometimes ambulatory 24-hour monitoring of blood pressure might be required, especially in very old individuals. There are certain physiological changes in older adults that predispose them to increasing blood pressures. So with aging, people really have increasing arterial stiffness, which leads to a widened pulse pressure. And in addition to that, the baroreflex sensitivity declines, so blood pressure regulation becomes very difficult for the human body. And the renal and sodium handling change leads to more sodium sensitive hypertension in all individuals. So these physiological changes combine together to increase the peripheral vascular resistance and arterial stiffness, which provide the best explanation for the relatively greater increase in systolic blood pressure and increase in blood pressure observed with aging. And decreased sensitivity of the baroreflex, perhaps related to decreased arterial distensibility, contributes to an increasing blood pressure variability and sympathetic nervous system activity. Apart from that, alterations in renal function as well as in neurohormonal systems that are involved in sodium balance also contribute largely to the increase in proportion of older hypertensive people whose blood pressure increase with increased sodium intake. Moving on to diagnose hypertension, we need an average of 3 readings, an average of several readings taken at 3 different visits to the hospital. If this cannot be done, we can consider ambulatory blood pressure monitoring, especially when we suspect white coat hypertension, which is hypertension that people experience when they visit a doctor and have their blood pressure checked in the clinic. So we always don't want to overdiagnose hypertension. So physicians should take care to not diagnose blood pressure solely based on readings taken at the clinic. So all the patients are encouraged to take blood pressure readings at their home and to monitor their blood pressure for a certain duration, which ranges from 2 to 4 weeks at least, and then we can be really sure of the diagnosis of hypertension, and then the patient can be started on drug therapy after at least 4 weeks. To clinically during the clinical evaluation for hypertension, we should always exclude three things. We should exclude any cause of secondary hypertension, and we should identify if there is any damage that occurred to any organ, especially the heart, the kidneys, the eyes, and the brain. And we should also assess overall the cardiovascular risk and lifestyle factors that might be the cause of hypertension, because most cases are essential hypertension, but in older adults, we should be vigilant for renovascular disease or hyperaldosteronism, which can cause resistant hypertension in elderly adults. So moving on, the good news is that treatment is very beneficial in hypertension. It reduces mortality, reduces the cardiovascular events, heart failure, and stroke. But the issue is that people, as I discussed earlier, are not very adherent to medication because hypertension is mainly asymptomatic. So people are not really worried about their diagnosis when they first hear about it. So they don't care much to start adhering to their treatment. And there was a trial called the hypertension in the very elderly trial, which showed that patients over 80 showed a 21% reduction in total mortality with treatment, proving that even the very old benefit from treatment and not a certain age group. Now we'll be discussing when should we actually start treatment for hypertension and what target blood pressure are we aiming for. So in general, we focus on the systolic blood pressure mainly and pulse pressure. So the target systolic blood pressure is usually between 135 to 140 and a diastolic blood pressure of less than 90. And for patients with type 2 diabetes, we aim for a slightly lower threshold in systolic blood pressure. So we aim for at least less than 130 millimeters of mercury. If the systolic blood pressure is very high, we may aim for an intermediate goal first. So for example, if the patient has a systolic blood pressure of 180 or 190, we don't aim directly for a blood pressure less than 140. So we might have an intermediate target. Let's say, for example, 160 millimeters of mercury, which will be our initial goal in the absence of target organ damage, of course. So remember, systolic pressure alone correctly classifies 99% of older hypertensives. Moving on to lifestyle modification. Before starting pills, we should always emphasize the lifestyle modification, which include weight reduction, aerobic exercise and strength training, smoking cessation, decreasing alcohol intake, and lowering the intake of sodium, saturated fat, and cholesterol. And we should also maintain an adequate intake of electrolytes, including potassium, magnesium, and calcium. So in non-diabetic patients with stage 1 hypertension, a 6-month trial of lifestyle changes is usually done before any medication is prescribed. And it's very effective because in a clinical trial, it was found that a modest 4-kilogram weight loss plus sodium restriction was able to reduce blood pressure by nearly 30% among individuals with blood pressure. So the lifestyle modifications are very effective and hence should be started first. If refractive to lifestyle modification, then only patients should be started on medications. So what medications patients are we going to start for an individual with stage 1 hypertension? So we usually start with a low dose diuretic, which is you usually choose the azide diuretics. And if the blood pressure is more than 20 millimeters above our target, we can start with two drug therapies at once, usually a diuretic plus an ACE inhibitor. And when we first initiate the drug, we usually start at a low dose, usually half the dose, and then increase it slowly until we reach the required target blood pressure. And we should avoid excessively prescribing antihypertensive medication so that we don't get a very low diastolic blood pressure. We usually avoid the diastolic blood pressure that is lower than 70 millimeters of mercury. And at the same time, we also don't want any adverse effects from the antihypertensive medications, which are very common in elderly. And the most important of them is postural hypotension, because then elderly patients may experience syncope and then they will fall, and it leads to a lot of complications, so it should be avoided. And we should also avoid the centrally acting agents, which are usually even IV, but like if the patient is treated in an outpatient scenario, you'll be started, of course, with oral antihypertensive. And the thing is, we should also keep continuing lifestyle modification, even if the patient is taking drugs, because many patients, after starting drugs, they stop relying on their lifestyle modification. They don't care anymore about their weight loss or their height, but it's still very necessary and important for them to maintain a healthy lifestyle in addition to taking their drugs. So as we discussed, the preferred initial therapy is thiazide diuretics, which are relatively safe, and they require only one dose per day. They are low cost. They are significant. They are very helpful in decreasing the risk for mortality, stroke, and coronary events. They are better than the other agents at reducing systolic blood pressure. And potassium replacement is very important because many diuretics cause hypokalemia and metabolic alkalosis. So uh, we should really take care when prescribing them for a long period of time. Moving on to ACE inhibitors, which can also be used as an initial monotherapy for hypertension, especially in patients who have an underlying chronic kidney disease, or if the patient has beginnings of renovascular disease. They should be started in ACE inhibitors instead of izates. They're generally well tolerated, but many patients also experience side effects such as a chronic cough with ACE inhibitors. So when they do occur, we can stop ACE inhibitors and we can start the patients on angiotensin receptor blockers instead. And so angiotensin receptor blockers are not very well studied in older hypertensive patients, and they're usually not started as an initial monotherapy, but they could be used instead of ACE inhibitors when patients complain of any side effects due to ACE inhibitors. As we discussed, they can be option for patients with diabetes, for patients with heart failure or CKD, and especially those who are unable to tolerate ACE inhibitors. Moving on to calcium channel antagonists or calcium channel blockers. So they reduce peripheral vascular resistance by blocking the calcium channel, and they usually have very slight adverse effects. And apart, like their only very common adverse effect is maybe probably lower limb edema, which is usually very minimal and not a very big issue for patients. And they usually used as a second line therapy along with a thiazide type diuretic, and they can be started at a very low dose, and the dose can be altered and changed with time. But we don't usually use short-acting calcium channel blockers to treat hypertension at all. They can be used in treating hypertensive emergencies or urgencies, but they are not used for the long term. Moving on to beta receptor antagonists, which are another class of antihypertensive medications. They are not usually recommended as a first-line monotherapy because they are less effective than diuretics in reducing blood pressure and preventing cardiovascular events, but they're very helpful in patients who have histories of maybe atrial fibrillation or any patient who we really need to control his heart rate in addition to decreasing blood pressure. So they can be considered for patients with coronary artery disease, those with a history of MI, and a few patients with heart failure. We also have another class, which is called the alpha receptor antagonists or alpha receptor blockers. This class of medication is rarely used for long durations, and because of its high risk of postural hypotension in older adults. And when used as monotherapy, they're associated with a high rate of cardiovascular events. But they may be used usually in combination with another drug, or they're used when two or three drugs were not able to control hypertension. They can be added to control hypertension, usually in hypertension that is resistant to therapy. Okay, so after starting drug treatment in hypertensive patients, the most important thing for a physician is to follow up the patient and for the patient to carefully monitor his blood pressure regularly. And this is very critical for the patient. We need to reassess the adherence of the patient to medication if there is any side effects to the medication, and we should measure his supine and standing blood pressure so that we can find out if there is any beginning of the onset of postural hypotension when the patient is with, which will be found when we find a drop in the standing blood pressure. So a follow-up every 1 to 2 months is ideal, and so that even drug doses can be adjusted so that we can either increase drug dose or decrease drug dose. So, and remember, if control is stable for at least a year, we can consider stepping down the therapy in appropriate patients. So if a patient, for example, was started into two hypertensive medications and his hypertension was well controlled for at least 1 year, we can consider decreasing his dose or at least starting him on only one dose and in only one drug instead of two drugs to decrease his dependence on pharmacological treatment. And when we adjust the therapies, we usually need to always assess and review all the medications that the patient is taking, because some medications might actually be causing the increase in blood pressure, and such medications are NSAIDs and corticosteroids, which falsely elevate blood pressure and hence cause the increase in blood pressure. So many patients actually, if we just like review their medications really well, we can find that many patients actually have blood pressure that is induced by other medication instead of it being a physiological cause of hypertension. So, we should also take care while increasing the dose of any antihypertensive medication, because as we said, it can lead to severe hypotension. That is not a good thing for any elderly patient. And if a blood pressure is not reaching the target after using 3 drugs, we can evaluate the patient for refractory hypertension. As we said, it can be due to him taking another drug, or it can be due to an underlying cause like a tumor secreting glucocorticoids, for example, or it could be due to severe renovascular constriction that can be causing the refractory hypertension. Moving on, we will be talking about hypertensive emergencies. So what's a hypertensive emergency? In a hypertensive emergency, there is usually acute organ damage that requires hospitalization and IV medication. So we usually, when treating hypertensive emergencies, we target a blood pressure of about 160 systolic by 100 diastolic within the first 6 hours. And we try to not decrease the blood pressure very rapidly. We need to decrease it in a slow stage and during 6 hours. Comparing it to hypertensive urgency is when there is no organ damage, is when like there is very high blood pressure without any organ damage. So this is not considered an emergency. So we don't need IV medication to treat this kind of patients. But we need to gradually decrease their blood pressure within the first 24 hours. Blood pressure in long-term care settings. So hypertension affects about 1/3 to 2/3 of residents of long-term care facilities, and this prevalence is very high. But the key issue is actually postprandial hypotension, which affects 1/3 of the residents, and which is a very high, a very important risk factor for falls, syncope, and stroke in individuals living in long-term care facilities. There is a clinical trial done that showed evidence that the management is, if management is individualized, aggressive control may actually harm frail patient more than it helps them. So we should always take care to not over treat patients, especially elderly patients above 90 or 95 years old, because sometimes very strong uh, control of their blood pressure is not very helpful for them. So we should always weigh the long-term benefit against the immediate risk that they go through. And the risk-benefit ratio, as we said, is not very clear sometimes. So patients older than 80 years with multiple comorbidities and who are already taking a large number of drugs, hypertension is really not very important in their cases, usually in patients who are taking more than 10 or 15 drugs. Hypertensive medication is important, but they're in a late stage in their life and really very critical. Monitoring of their blood pressure will not be very helpful for them. So to summarize, what we just talked about. So treating hypertension saves lives, especially in older adults who are in risk of many cardiovascular events, including MI, strokes. And secondly, lifestyle comes first always. We should always try lifestyle modification before starting any kind of drug. And regarding drug types, always or most of the time, low dose diuretic of the Alzain type is the preferred first line drug therapy in stage 1 hypertension. And you should always monitor for side effects, mainly postural hypotension in all adults who use antihypertensive medication, and we should use the motto start low and go slow. So we should actually always treat hypertensive patients slowly, aiming for a target blood pressure that is not very far from the blood pressure they have currently, and to slowly increase the dose as we move on. So here's a question about hypertension. We would like you all to engage in answering the question. So the seventh report of the Joint National Committee recommends which of the following for initial treatment of hypertension in older adults. So these are the different classes of antihypertensive medications: ACE inhibitors, thiazide diuretics, calcium channel blockers, beta blockers, and ARBs.
Diuretic.
Yes, correct. The answer is thiazide diuretic. As we mentioned, thiazide diuretics are the first line monotherapy for people with stage 1 hypertension. Okay, I'm asking another question. When can ACE inhibitors be used as an initial treatment for hypertension?
Associated condition like chronic kidney disease or diabetes patient.
Correct. Yes, exactly. Correct. We can use the ACE inhibitors in patients with an underlying condition apart from hypertension, like chronic kidney disease or diabetes. Okay, here we have another question. A 70-year-old man comes to the office to establish care. He's generally healthy and has always had normal blood pressure. His family history includes diabetes and hypertension. His father died of a stroke and his mother has cancer. He eats a low sodium and low fat diet. On examination, his blood pressure was found to be 150/90 without any postural change. Cardiac examination was normal, and there is no evidence of hypertensive retinopathy or peripheral vascular disease. His laboratory studies, including creatinine, was normal, ECG was normal as well, and at a repeat check 1 month later, his blood pressure is 154/92 without postural change. The patient reports that the reading taken with a friend's blood pressure cuff was 134/80. So, guys, what do you think is the case of this patient here? So, as earlier, the patient is 70 years old and always had normal blood pressure. So, why in examination he always has a blood pressure of more than 150/90?
White coat hypertension.
Yes, exactly. This patient has white coat hypertension, which is hypertension that's related to clinic visits. And as mentioned here, he had a reading taken with a friend's blood pressure cuff, which was 134/80. So we can know that this patient actually has normal blood pressure, but is only increased inside the clinic. Okay, so in this case, which of the following is the most appropriate next step in managing this patient's increased blood pressure?
In 24 hours. Ambulatory
Yes,
blood pressure
exactly.
record.
Yes, exactly, Dr. Nadia. We can obtain a 24-hour ambulatory blood pressure to make sure that this patient is not actually having hypertension, and so that we can prove that this is actually white coat hypertension. And as you can see, option E is begin a hydrochloroiazide, which is a diuretic and is usually the mainstay treatment for stage 1 hypertension. But we are not really sure of this patient's diagnosis of blood pressure, so we cannot jump and just start him on treatment directly until proven that he has blood pressure. So this was a very tricky question. And yeah, so the answer is obtaining 24-hour ambulatory blood pressure report. This way we came to the end of our short talk about hypertension. I hope you all really benefited from this talk, and thank you so much.
Thank you so much, Dr. Kareem, for this great presentation. Does anyone have a question? If no one has a question, we can move to our next topic, research career development, presented by Dr. Mahasin. Dr. Mahasin, whenever you are ready, you can start.
Hello everyone, I'm Dr. Mahasin Mohammed Ahmed. Yes, I'm ready. I'm gonna share my screen with you guys. Is my screen clear for everyone or not?
Yes, it is.
Okay. Okay. Good evening or good afternoon, depending on your time zone, guys. Today, I will be talking about research career development, especially how to develop a research portfolio and balance clinical work with the research. Okay. As clinician, we know that research is what drive advance in the patient care. Sorry. But beginning post a clinician and the researcher mean you are balancing two demanding rules. In this presentation, I will cover three main areas. The first, the fundamentals of the clinical research, clinical research methodology. The second, strategies for the career development and the portfolio developing, portfolio
Dr.
building.
Mahasin, I'm sorry, I think your screen is frozen. Okay.
Okay, sorry.
Did you move to the next topic? Okay.
Yeah,
No,
okay.
thank
Sorry.
you.
Okay, develop career development and the portfolio building. And finally, a practical way to balance clinical work with the research. Okay, let's start with study designs. Experimental studies like randomized controlled trials are the gold standard. The investigator of the and the investigator and the intervent and the assuming treatment. Observation study do not interventions. These include cohort study where we follow group over time, case control study where we compare people with or without a condition, a cross-section study with which give us a snapshot at one point in time. Okay. Randomizing and blind, two essential tools for improved research quality and are randomizations and blinding. Randomization assessing participants by chance, which reduce selection bias and balance and balances. Blinding prevent participant investigator or assessing from knowing who is in which group. The more level of blinding, single, double, or even triple, the less like bias will creep into the result. Okay, when we talk about study quality, we need to consider validity. Internal validity is about whether the study design produce accurate accurate result within the sample studies. External validity is about whether we can apply those results to broader population. Common bias threatening validity. For example, selection bias when groups differ at the baseline. Recall bias when participants cannot remember exposure accurately. And observer bias when researcher expectation influence outcome. Okay. Statistics are critical to interpreting research. Adequate sample size and the statistical power make sure we can detect true effect. We also need to control for confederation and use intention to treat analysis in trials. Equally important are ethical consideration, informed consent, protecting confidentiality, and ensure oversight by ethical committee. Research must comply with the good clinical practice and the acceleration of health thinking. Okay. Research career development. Now let's shift to the career development. Mentorship and the network are key identifying a good mentor early and building collaboration across disciplines. Developing skills in grant writing, study design, statistic, and leadership is essential. Your responsibility will grow over time from a small project to large multi-center collaborations and eventually independent funding. Professional visibility also matter. Present at the conference, engaging in peer review, and contributing to academic community. Okay. A strong research portfolio demonstrates both depth and breadth. High quality publications are foundations, especially first and the senior author papers. Grant funding aids start with a pilot or seed grant, then move toward large national award. Your portfolio should be devised include clinical trial reviews, methodological work, and even contributions to educational and mentorship. Importantly, you should show how your research translates into the better patient care. So, one of the biggest challenges is balance. To protect research time, it's helped to negotiate the dedicating blocks with your time with your department and treat them as seriously as clinical duties. Integrating research into clinical work is power. Many of the best questions come directly from the patient encounters. Time management is crucial. Block time for writing, prioritize projects with the high impact, and delegate it when possible. And for long accessibility, avoid overcommand and build supportive multidisciplinary teams. So to wrap up, a successful research career requires both scientific rigor and the strategic planning. Methodology ensure that your research is credible. Career development strategies and a strong portfolio ensure your work is recognized. Balancing clinical duties with research is challenging, but with mentorship, structure, and prioritize, it's possible. It's possible to achievable. Thank you.
Thank you so much, Dr. Mahasin, for this great presentation. Does anyone has a question?
Welcome, Dr. Milas.
Okay, so if no one has a question, we can move to our next topic, which is confidence interval, presented by Dr. Mohammed Makawi. Dr. Mohammed, you can join whenever you're ready.
Hello everyone, my name is Dr. Mohammed Makawi. I'll be talking about confidence interval. So this one will be a short one. It's not too much to talk about. Okay. So what is the confidence interval? Well, it's actually just a range of values which are consistent within the data. For example, we have a large population of about 1 million. And we are trying to find the average, what is the average weight of the people in this population. So it's difficult for us to be sure that we are able to get the exact mean of all this, of the weight of the people in the population. So we go, usually we go with a range, and usually we go with a range of 95% interval, confidence interval. It's the standard range that we always use. And so when we say 95% confidence interval, we mean that if we do the study 100 times, 95 times of them, we will the confidence interval will contain the true population value. Like 95% of the time, we will get the true mean of the weight of the population that we have just given in the example. Commonly it's done by 95%, but it can also be done by 90% or 99%. But 95% is the standard. Furthermore, we never use 100%. Why? Because 100% means that our range will be from minus infinity to infinity. So it's not done at all. So it's at most 99%. So we can see in this when we have a normal distribution patient, let's say the mean is 4.27. The upper limit will be 5.62 and the lower limit 2.92. It's the 95% confidence interval. So we are 95% sure that the population of mean will be between 2.92 and 5.62. Then we have outliers before and after, which is about 2.5%. So how do we calculate it? Normally we use this formula. Confidence interval is the sample mean plus or minus the confidence level in value and times the standard error. The standard error is the standard deviation over root of sample size. So just do a simple example. Let's say that we have an orchard of apples and we have 15. We took a sample of 15 apples. The sample mean of the apples that we have is around 149.3 grams with standard deviation of 4.758. So then the Z value will vary depending on what percentage we take. So 95%, the Z value is 1.96. So the confidence, so once we put in all the equation, we get the answer confidence interval of 149.3 gram plus or minus 2.4 gram. Then which translates to 146.9 to 151.7. Notice that I prefer to use the last one, 146.9 to 151.7, for a very important reason here. It's something interesting that a review was done on 88 articles published in 2002. Showed that 14% of them failed to identify which measure of dispersion was reported. So for example, if we just simply write 149.3 plus or minus 2.4, they don't mention what type of measure of dispersion is. It could be range, it could be confidence interval, it could be dispersion of mean. So this will cause the paper to lose its value because the one who's reading it will not be able to know what are you trying to calculate here. So many journals such as the BMJ, they advise to remove the signs and request to clearly indicate whether the standard deviation or standard error is quoted, and recommend that all journals should follow this practice. So this is about confidence interval. So how do we interpret it? As physicians, we are always exposed to many types of papers and many types of researches. One common example is about related to efficacy of a new drug compared to a drug that we commonly use. For example, let's take this example. We have a new diabetic drug called drug A. It's compared to a standard drug that we commonly use, let's say metformin. Then they compare how effective this new drug reduces HbA1c levels compared to metformin. So we get a relative risk of 0.8 with a 95% confidence interval of 0.7 to 1.2. Okay, so this is the result that has been given. You notice that the p-value here is 0.7. Since it is greater than 0.05, it means that this result is not significant. But even without this p-value, from the confidence interval itself, we can know that whether it is significant or not. Notice that the confidence interval crosses the value of 1. It ranges from 0.7 to 1.2. This one is something that we call the null value. That is when the relative risk of the experiment and the risk of the experiment and the control drug are the same. So this is called the null value. If the confidence interval crosses this null value, this result is not significant. Why? So you can notice that it ranges from 0.7. So it means that this drug can lower the HbA1c level by 0.7, or the other end 1.2. It means that it can increase the HbA1c level by 1.2. So this drug has a chance of either decreasing HbA1c or increasing HbA1c. So this doesn't make sense that we should use a drug that for some people it will lower the HbA1c and for others it will increase it. Therefore, this result that it showed that the relative risk is 0.8 is not significant, and we do not use this. Another example, let's take another drug Z. It lowers cholesterol level. Okay, compared to standard drug atorvastatin that we commonly use. Here, the relative risk is shown to be 0.6, with a 95% confidence interval of 0.4 to 0.7. So here we can see that both extremes 0.4 and 0.7, both of them the range does not include the null value 1. They are both below 1. Therefore, this result here is significant because they are both below 1. The opposite could be also if for example, if you give a drug that increases HDL level, and you get a relative risk of 1.2 with a confidence interval of 1.1 to 1.3. Both of them these two ranges does not include the null value 1. Therefore, this is significant result. So here, since the range does not cross the null value, it is both of them are still below the null value. This result is significant. So we can consider that this drug Z, is better in reducing the cholesterol level compared to atorvastatin. And that is all. Thank you very much for listening. If you have any questions, you can post it in the comments.
Thank you so much, Dr. Mohammed. Does anyone have a question? If no one has a question, we can move to our next topic. 10 steps to being more sociable, presented by Dr. Alzain. Dr. Aya. I'm sorry, I cannot find Dr. Aya among the participants. And also I sent her a private message, but she didn't reply.
That's fine. We can move on to the next item in the agenda. Maybe we will see if there is anyone with the updates.
Dr. Iram, she can join now, I think.
Hello, everyone.
Hi, Dr. Iram. You can start now.
Okay. Hi, everyone. My name is Iram Reza. I'm one of the research fellow. There, 1 second. Firstly, thank you so much, Dr. Nadir, for giving me this opportunity to present my app. First, I will share my screen. My screen is visible to everyone?
Yes.
Okay. So I'm going to present an app. It is basically an app for elderly patients with heart failure, and it is basically a health tracker for their heart. So it includes 6 components, like it tracks their vital signs and symptom management. And the third thing is in it is medication manager in it. And the fourth thing is lifestyle tracking. And the other thing is it includes health reports. And firstly, we will go to the vital signs. So in the vital signs, they can record their vitals like blood pressure, heart rate, weight, temperature, and blood sugar every day to keep the record of their vital signs, so that at the end of the week or at the end of the month they can they can track the record of their vital signs, and they show trends how their vital sign goes with that heart failure condition. So first I will give you an example of that. Like if I put 130 in it, 130 systolic, diastolic BP is 90, and heart rate is 75, or weight is 170, temperature 98.6, blood sugar is 95, and you can put any additional notes about your readings or any other thing, and it goes saved automatically. Like vital signs are saved successfully, so it got saved into the vital signs tracking tab. And the next thing is that so it will appear on the today's reading site, like below the app it appears like this. And it also recorded the recent, it also shows the recent history as well. And the other thing, it tracks the symptoms of the heart failure patients. Like in symptoms, that if we go to the symptoms tab, there are different checklists for the symptoms, like if the patient has chest pain, dizziness, headache, shortness of breath, fatigue, or nausea, with the severity scales like 1 to 10, they can record. If the patient has feeling some dizziness or headache, we can record the it can record the symptom, and it shows on the scale like severity is 5. So, and next is duration. Select the duration. We can how long they are like feeling these kind of symptoms. So it's been less than 1 hour, for 1 to 6 hours, or it also like displays the duration of the symptoms. So it's save the symptoms automatically, and with that we have like it shows up below the save symptom signs, today's symptoms, how the patient is feeling. And there is also a tab for emergency signs, like it shows the what is patient automatically knows what is the emergency signs of the heart failure, like severe chest pain, difficulty breathing, loss of consciousness, sudden severe headache. That's the alarming symptoms. So the patient are, if they knows the emergency signs through the app, they can able to call to 911 or to the emergency situation. So by keeping the track of their vital signs and the symptoms, they can track their health record, they can track their heart health in this way. And they shows and next app is, and the next step, sorry, is the medications. So in the medication management, we have we can put the medication name, dosage, frequency, how it's once a day, twice a day, thrice times daily, or as needed, and the timing of the dosage. And it also includes the purpose while they are taking for blood pressure or diabetes, as these are the common causes of heart failure, and it automatically gets added into the add medications. Like if I put lisinopril, and if they are taking 10 mg, and frequency is once daily, timing is 8 a.m. and with food, it also includes if they are taking, if the medication is with food, without food, or no preference. So we can put it no preference, and is let's suppose patient is taking for blood pressure, so it add medication. So in this way we can add the medications in their app so that they have medication reminders, they do not miss their medication. In this way patients are adherents to their medications. And the other it shows the current medications patients are taking, and today's, there is a tab for today's schedule. If it also shows if the medication they will going to take it, or the medication is taken. So next tab is lifestyle modification with the scales. So if the patient is having exercise, if let's suppose it if the patient do 30 minutes exercise, or it has 30 minutes we can put, and have 5 hours of sleep, and the glasses of water, if he's been taking, how many glasses of water he has been or she has been taking, we can put if 3. Or the mood, today's mood, it can also show you today's mood. You can put the today's mood in it. You are feeling very, if the patient is feeling very sad, neutral, happy, or very happy, so we can put the neutral one, and we can save lifestyle data. So according to the lifestyle data, it keeps the record, and it shows the weekly goals like exercise or sleep. And it all, according to the data you put in, it records the data, and it gives you the tips about the nutrition, about the exercise. So it also gives you health tips at the end of your recordings. Last step is the reports. So it shows how many entries, how many symptom entries, how many vital entries you did, or days tracked. It shows days tracked, or it also gives you at the end the average health score out of 100. So, and the streak, it shows the consistency of the days patients are putting their heart health record actually into the app. So it has also advantage of patient can generate their health report. So by putting their vitals and symptoms and the lifestyle tracking patients have can show their health. It gives you a health insights, excellent blood pressure, great exercise consistency, or sleep improvement opportunities. So it shows, and here it shows the recent data you put into the app. If we can talk about the dashboard of the app, so it pop up like this. It is very senior friendly app. You can see the health score tab, today's activity, how many entries are, and the quick status, blood pressure, heart rate are shows on the like dashboard. You can see the or any health alerts patients have, like vital signs, if their blood pressure is going up, if they haven't taken any medication or exercise goal. So it on the above dashboard we can see it is an online and show the timing. But the main advantage of this app is it works offline is as well. No internet is required for this app. So it's a simple app. We can patient with heart failure can record their health activities, and their if they have any alarming symptoms, they can it also pops up in this app, and they can contact the emergency or emergency contacts in case of emergencies. So that's it from my side. Thank you so much, everyone. Hello.
Thank you so much, Dr. Irma. This is great, and I think it's a very useful app. It's simple, but it has many features that I think the users or the patients may benefit from it. So if you are open to create a team and maybe some other fellows may be interested, they can contact you so that you can work together and maybe see if there is any feedback and see how we can test it with other fellows, family members, and see if we can distribute it or put it online. And
Okay.
in the future, maybe we can even put it in Apple Store or Google Play Store. Thank you.
Okay, Dr. Nadir. I will sure develop a team and share my app to every fellow. Thank you so much for giving your time and seeing my app.
Excellent. Well done. Thank you so much for sharing.
Thank you.
Anyone else?
Also, Dr. Hajir, she has another mobile app.
Hello, everyone. Can you hear me?
Hi. Yes, we can hear you.
Thank you so much for this opportunity. So let me share my screen with you. Wait. Okay, can you guys see? Can you see my screen?
Yes.
Okay.
Yes, Dr. Hajir, we can see your screen.
Okay. So the app I created today is FibroCare. Basically, it's an app for fibromyalgia patient. I chose fibromyalgia because it affects maybe 4% of the population, mostly women, and it often goes underdiagnosed. So the app is fairly simple. So the main characteristic of the app is it's symptoms and pain tracker. Okay, so you can track your symptoms here. The patient can choose the pain level here. So let's see, the pain level is 6 today. And also all of the symptoms of fibromyalgia, mainly pain, energy level. So let's see, today energy level is moderate, and the mood. The patient is happy today. And then they can choose additional symptoms, like fatigue, sleep issues, headache, brain fog, stiffness, and digestive issues. And then they can plot any notes or any additional symptoms they had today, not mentioned on the app here. Then there is wellness tools, breathing exercises. They can start the breathing here, the breathing exercises, which is the 4-7-8 rule. Inhale for 4 seconds, hold for 7 seconds, and exhale for 8 seconds. And then they also remind them to do gentle stretches or meditation, sleeping tips. It also offers sleeping tips. I just cannot open it here. It's not opening. And then nutrition guides or pacing strategy, like manage the energy through the day. What's mostly important on this app is the resources. There's educational resources so they can understand fibromyalgia better, pain management technique, and exercise guidelines. Also support and community group so they can meet other people with other patients with fibromyalgia, and then they can support each other. Also healthcare tools. And then important emergency contact. If any crisis happen or they can see any doctors, and then the emergency services. It's a very simple app, but I think it's very important because fibromyalgia, as I said, it's underdiagnosed. And yeah, that's it, to be honest.
Thank you so much, Dr. Hajir. Again, this is well done
Thank you.
for the app. Thank you. Dr. Hajir or Dr. Iram, maybe you can both share your experience. How did you come with the idea, and how long did it take you to use Canva and improve, or how did you do the app?
Of course, I'm gonna go first. So firstly, I came up with the idea because of how complex fibromyalgia is, and excuse me. And there are few comprehensive apps for this for fibromyalgia. So it took me maybe 1 day to come up with the idea and 1 day to create the app. I used Canva to create the app, mainly Canva to create the app, and it was a fairly easy process.
Great, thank you.
You're welcome.
So Dr. Nadir, for me, I choose the heart failure specifically in elderly patients, as I was in the. I decided last month, and it took me 1 month to develop this app. I was at that time I was working at a geriatric clinic in Michigan, and I saw a lot. So I saw these kind of patients in at that clinic, and it becomes the and I thought it would be a great idea to create an app for elderly patients with heart failure. So, and it took me around 1 month to work on this app, or to make it a better version of it. So that's it from my side. Thank you.
Thank you both. Thanks for sharing your experience. So anyone, a few guys, they can come up with similar ideas like for your patients, different patient population. And using Canva, it's an easier couple of steps. You give the prompt and it will create the first version for you, and then you can test and modify and edit and see how you can add more features and so on. So thank you for sharing. I think it's a simple way of developing something useful for your patients.
Thank you, Dr. Nadir.
Thanks. And for Dr. Hajir as well, if you want to create a team, ask the fellows who are interested in family medicine, internal medicine, because they can see a lot of patients with fibromyalgia, and they can join you. They can translate that maybe to Arabic language or other languages. They can test the app. They can see if there is any other features maybe we can add. And also down the road, maybe you can think about adding it to Google App or Apple App Store. Thank you.
Thank you, Dr. Nadir. I will do that.
Great. And this will be very helpful for you guys when you apply this year or those who will apply next year. But it will highlight some innovation approach in your CV and how you can improve your application. And during the interview, maybe you can talk about your experience as well, how to develop that and how to create the team, how to test and so on. Thank you both. Dr. Ryan, go ahead.
Assalamu alaikum, everyone. Hello, Dr. Nadir. I would like to ask about how to deploy the app. I'm currently working on an app for simulation to use it in medical education. But I want to ask about how to get a host and how to create URL to publish the application.
Great question. So it depends on how you created your app. What tool did you use to create the app?
Canva.
Canva. So most likely it's gonna be similar to the two apps that I presented today. It's a web-based, most likely. And to host that, there are a couple of options. I'm gonna show you.
Actually, I tried to have an account on GitHub and then to copy the code on the repository and try to use or to share it with Netlify, but it doesn't work for me. When it comes to the deployment, the last step, which is post-processing, it stopped there. I don't know where is the problem.
Can you maybe after this meeting stay a little bit longer? We can work together if you share your screen, and I can try to help you.
Okay, great, thank you.
Welcome, no problem. Thank you. Anyone else?
Hello, Dr. Nadir.
Yes, Dr. Syada. I was going to.
Sorry for that. I also would like to share our application. So a few weeks ago, I have came with the idea of mood depression or depression tracking application, mainly for adolescents, as there is no application is specified for adolescents with depression. So I came up with that idea and I presented for you, Dr. Nadir, and then I worked on the idea itself, what the application would be included, and then we form a team of 8 members, and with assistance of the application developer, now our application is ready. So I would like to present a demonstration. So if you have any feedback, I will be more than happy to work on it before getting it published.
Go ahead.
Okay, thank you so much. I will share my screen. Okay, let me try. So can you see my screen now? Is it clear?
Yes.
Okay, so the application name is Mood Body. We make it something like more attractive to teenage group. So the first page, the email and password signing, or you can create account. Once we need to create an account, then we need to enter the first name, the last name, and the age. The age is supposed to be 10 to 19. We will read that, because if we enter like 20 or age above the 19, not in the teenage group, then it will not be accepted. Okay, so let's just try to enter. And then let's make the age 17, for example, and then continue. And then it will ask you for email, password, and confirm the password. Okay, let's enter. This is mine. I have already created an account. Okay. There's an option for parent or guardian email if it's optional. So if you would like to add it, it will take you to that. Then the medication. So you can add the medication that you are taking, because in the application there is a notification for the medication for taking your medication. So let's say that I'm taking fluoxetine. Let's say the dose is 200. Then how often you take it? Let's say daily. And then you create the account. Okay, because I already have one, so I would go back to sign in, to log in. But this is to show you how it's look like. So we have firstly daily check-in, and then we have learning and resources that can be useful for the users. Then we have AI support, AI chat. You can use it to speak, the teenage can use it to speak with or to chat with AI to give them a support and kind of hints that can help them, and the progression. So let's go for the first one. Daily check-in. In the check-in, which will ask you about the mood. So from rate 1 to 10. So 1 is very low and 10 is amazing or good mood. It's in a very simple way. You don't want to make it very like complex, because teenage tend to feel bored of everything. So if give it more details, it will they will not likely to answer it. So we just wanted something to be very easy for them to answer it, or to just pick it up and give us answer. Then the sleep, how was your sleep? Let's say 3, it was okay. And then we'll ask about the energy level, the same from 5 to 10. And medication, did you take your medication today? If you don't have medication, it will give you an A option if no medication for the patient. So let's say yes. And then a good thing about today, or something you did it good today, it's give you kind of motivation. So you can say anything, like today I met my friends. Let's say that. Okay. And then the second part is learning about the depression. There's resources from the web of NIH website, and some from Mayo Clinic. So for example, you have understanding depression. There's articles speaking about depression, and some YouTube videos in here. This one, like for example, you can open it. It's from the official website of NIH. Okay. And let's go back. Some YouTube videos also. And about the coping strategies, the same resources. And then we have getting support, like how you get support, to whom you speak to, like for this one, this article from my clinic, or just take time. Okay, I will show the rest till it open. Then we have the wellness tips. Here. Like teen depression from my clinic, expert guide in recognizing and treating teen depression. So all these helpful resources can be used by the users to help them to know more, to educate themselves selves about the depression. Okay. The other part of it is AI support. So you can start chatting with AI. So let's say you say, I feel sad. It's give you some sort of support and advice on how to act. It's here. I'm really sorry you're feeling sad, Sayda. Do you want to tell me more or what's going on? Sometimes sharing what's in your mind can help you to lighten the load a little bit. So it's give you some sort of open questions so you can speak more. But if you reach a level of like suicide, kill yourself, or something like red flag signs, it will guide you to speak to your doctor or to go for the crisis line. In the application, crisis resources is there. This one for the USA, but we will add according to the countries as well, the crisis or hotlines. And the last part of it is the progress. It will show you the progress for the check-in you have entered as a patient. So this for mine that I just entered, the mode, the sleep, the energy, and the medication adherence. Okay. That's everything. So all of the icons here representing the application, the home, the check-in, the chat with AI, the progression, and the profile. So yeah, that's all. And I would appreciate any feedback from you, Dr. Nader, and the fellows. Thank you.
Thank you, Dr. Syada. This is excellent one as well. Wonderful. Awesome. I
Thank
think
you so much.
very useful. Yeah. Any feedback for Dr. Syada or other apps like Dr. Hajir or Irma?
Hello, good evening. I have just a slight feedback regarding the sleep rate. You have 5 points for the rating. Just I think if you add the hours, for example, for me as a user, when I should, for example, put my, for example, 3 rate for my sleep or 4. Just add a slight hour, for example, 1 is less than 2 hours. In 2, for example, from 3 to 4 hours, that will be good, or just give reflect to how he can assess the sleep. That just
Yeah, that's great idea. Yeah, that's great. We can work on that definitely. But do you think as a teenage it will be complex to just add the hours, or we can make it like ready there as a button so the user can choose it, right? It's better than enter it manually. Is that what you're suggesting?
yeah, yes, no, it's just you put the, for example, the rate or when. So when I push one, that if I, for example, sleep 2 hours, so just I want the user, he know how he can rate this from 1 to 5. It is
From the
small.
hours of the sleep, not all of
Yes.
the quality.
Yes. Yeah.
Okay,
That's what I
that's
mean.
great. Actually, this is very great feedback. Thank you so much, Dr. Yusra. Thank you so much.
Thank you. It is even interesting one.
Thank you, my
Thank
dear. Thank you.
And again, I'd like to suggest if you want to create a team, Dr. Syada, for those who are interested, maybe you can ask them to join, test the app, see what improvement, if there are any bugs. And also if you want to translate it into other language, Arabic, for example, or something like that. So more people will be involved and they can help, and hopefully the app will help other patients. Thank you.
Okay, sure. Thank you so much, Dr. Nader. Thank you for your support and your time.
Anytime. Thank you. You did the hard work.
Thank you.
Any other comments, any other suggestions, any other ideas, or any other? Go ahead, Dr. Ahmed, for a
Hello, Dr. Nader. How are you doing? I would suggest if it's possible that the whole fellowship can collaborate to make a single app. Uh, uh, we will have time to make it perfect. I want the idea in my head is to create an app that represents the fellowship. It will be the main app produced by this fellowship in any aspect of medicine, like the CKD, like the fibromyalgia, but it will be a single app that we will work on it till it become complete application, and then try to take the approval and complete it into a full mobile app to represent the TGRF, and then we can publish it either on the iOS store, App Store, and take the necessary approvals for using it. I think it's a good idea.
Thank you
The
so much.
whole fellows can collaborate in it.
Thank you, Dr. Ahmed. It's a great idea. So we can work on developing something in the back, and then we will get the fellows involved as they see what things they can contribute to. But my idea is every one of you is applying to maybe a different specialty. Some of you might be interested in geriatric or family medicine, internal medicine. This will be as one group. Some of you might be interested in going to psych, and this is another group. Some might be interested in neurology or pediatric or GI or something. So for you to see which area you are interested in and try to work on something that will show your interest, and also it will give you an opportunity to excel and show your enthusiasm when you are talking about your project. So whenever it's specifically to the area where you are interested to apply to, it will be easier for you to display that and to talk about that during the interviews instead of giving a generalized idea. I worked in a very big project, but I think it's a good idea. Nevertheless, I want you to, every one of you, to work on something that's not necessarily unique for you, but at least in the specialty or in the area of interest for you, so that you can enjoy what you are doing. At the same time, you can put it in your application. You can talk about it during the interviews, and perhaps it's going to be a product that you can give to your patients if you are able to publish it online, just as a web-based or in the app stores like Google or Play Store. This is my approach or my idea about innovation in this program. So wherever you are able to do as simple as possible, you can do it alone or you can work as a team. You can make it bigger as much as you want to. In the past, The dental group work on one project and they publish it in Apple Store. I think it cost them amount of, if I'm not mistaken, $10,000 or something. But they collect it and they work together. They hired someone and they started with 2,000 and then upgraded that and so on. Other groups worked on other 5 apps. They were successfully published in Google Store, Play Store. So you can work on getting that published, and also hopefully it will help the population of patients that you serve. Does that make sense? Thank you.
Yes, thank you so much, Dr. Nader. Thank you so much.
You're welcome. Thank you. Anyone else or any ideas, any suggestions, any questions? I know some of you are applying to the residency through IRAS. So if you need any letters of recommendation, please let me know. You can use the app to highlight what you achieved or what's your task and so on, so that when I write the letter, it will be personalized. If you did not participate in the past, there are plenty of options for you to present in the coming meetings. Or as the fellow showed you today, you can come up with an idea of developing an app. You can use Canva with simple prompts. Even you can ask for ideas and then use one of these ideas to create the app. Thank you so much. And I'd like to thank all the presenters from today's meeting and Dr. Marwa for organizing this, and the other team members as well. Thank you for attending, all of you. And I'd like to thank all those who will come and watch the recording in the future.
Thank you, Dr. Nader. Thank you so much.
Thank you. Have a good one.
Thank you so much, Dr.
Thank you, Dr. Nader.
You're welcome.
Thank you.
Thank you, Dr. Nader.
Thank you, everyone.
Thank you, Dr. Nader.
Anytime. Thank you, Dr. Marwa. So, Dr. Ryan, if you're still there, maybe we
Yes.
can work on the project. So you used, I presume, an AI to develop your app. Is it Canva or something else?
Yes, I used Canva and I tried to share it with you, Marfa, إذا وصلت الإيميل.
Can you share the screen?
Okay. معلش سوري دكتور نادر، ما عارفة إذا ممكن يعني اسحب لك في الإيميل وتفتحه، لأنه ما عارفة في مشكلة ما تشوفه، ما قادرة أشوفه السكرين.
سوري ما سمعتك، قلتي ممكن ترسليه بالإيميل؟
أنا عملت شير من كانفا نفسه في الديزاين، عملت شير في الإيميل يعني.
لا ما تعملي، اعملي شير للسكرين بتاعتك. You are using your computer now?
لا no تابلت.
Yeah, can you share the tablet, the screen?
ما عارفة كده ظهر.
Yes. Yes.
هي الفكرة يعني هو عبارة عن simulation يعني for rural residency بسبب الكونفليكت السي، فكان في جزء من الستودنتس اللي بيكونوا برا السودان ما بيقدروا يمشوا الفيلد، فكان بيعملوا فيرتشوال يعني عن طريق البير ريفلكشن، بيجوا الناس اللي مشوا بيحكوا لهم الحياة اللي حصلت وبيعملوا تاسك معينة. فأنا فكرت إنه هل ممكن إحنا نعمل آب، والآب يكون فيه يعني حاجات learning outcomes و standardized task إنهم يستعملوها. ما أعرف، حاولت إنه أعمل حاجة ممكن يعني أرسل لك البرومبت اللي استعملته إذا فيه مشكلة أو فيه حاجة ممكن أصلحها، وبعد ذاك أحاول تست الأب.
That's fine. Yeah. Why don't you send me the code when you are using Canva? There is a way to show the code, and you can send me the copy of the code.
هو أنا صراحة ما عرفت إنه كيف أعمل كوبي للكود
ممكن
بالشكل
تعملي
بتاع.
publish as go back to Canva, and on the right upper top corner there is a share publish website.
أيوة.
So it's gonna create it as a website and publish it. Publish it.
I'll try to publish يعني هم سألني إنه أعمل يعني URL.
Yeah. Just
فما
publish it, and you just put a name, whatever name, just any name. Okay. That's okay. That's enough. Don't make it. Yeah. So click on view the website and copy that website. You can put it in the chat or you can send it by email. Can you hold on just a second, okay? I have someone to fix a faucet. I'm gonna be with you in a second, okay?
Okay.
Very good. Yes, honey. What do we got going on? I need your help to and when out, I want to replace this with this. You gotta do that, how much it costs? Yeah. The first one is it doesn't have valves yet, so you have to shut the whole thing off. Or this side valves. Okay.
So we look at that. Work. You're looking at 406.25. $406.25. If I want you to only put the valves, 2 valves. You only put 2 valves on there? Let me see what's there. Gonna be through 2 valves. We got $290.50. $290.58. Okay. Go ahead. What do you want me to do? Just the valves? Okay. Yeah. Thank you.
Hello, Ryan. Did you send it by emails?
No, I just sent the prompt that I used to create the app
Okay.
in the
Just
chat. Yeah.
so it's working for you, Ryan.
Yes.
Okay. And you wanted to publish it, you said, or you wanted to do what exactly?
Yeah, I want to deploy it to be able to share it with the student.
So now it's shareable. Now you have the website, and you can share that website. So
Okay, so I don't need a host or something to create a URL.
no, you don't need. It's the URL you just have now.
Oh, okay.
That's the URL that you want to share, and that's it.
تمام. اوكي انا هجرب وبعدك اشوف اذا في مشاكل تانية ظهرت او كده.
Sounds good. Let me know.
شكرا جزيلا دكتور، جزاك الله خير.